One way that we've heard that researchers are harnessing the power of ctDNA is by using it to monitor for treatment resistance. One trial taking this approach is the phase 3 SERENA-6 trial. This trial, focused on those with metastatic estrogen receptor positive HER2 negative breast cancer, is testing whether switching treatments when a specific mutation is detected in the blood versus when the cancer progresses on a scan, and seeing if this can improve outcomes for patients. While this approach has been used in other types of cancer, this is the first large-scale trial in breast cancer to use ctDNA to inform switching treatments during the first line of therapy. The first results from this trial were recently presented at the 2025 ASCO annual meeting. Dr. Wander told us more about this trial and what the results could mean for patients.
So these are patients who have metastatic hormone receptor positive HER2 negative breast cancer who were just relatively recently diagnosed and are on their first line therapy. So that's the aromatase inhibitor with a CDK inhibitor. The concept here is that mutations can arise in the gene that encodes the estrogen receptor. This is called ESR1. If you look at breast cancer patients who have just been diagnosed either in the early stage setting or in the metastatic setting, and they haven't received a lot of prior therapy, the frequency of mutations in that gene that encodes the estrogen receptor is extremely low, probably on the order of less than 5, less than 3%. But when we watch over time and we then retest tumor DNA samples in the blood from patients who have had a couple of years, for example, of endocrine therapy with an aromatase inhibitor, you start to see the frequency of these mutations increasing substantially, up to about 25 to 40% of patients. This is a way that the cancer can find its way around the treatment. These mutations allow the estrogen receptor to be turned on regardless of whether estrogen is present, and that causes the therapy to stop working. So there's been a big need in metastatic breast cancer to develop newer, better endocrine therapies that can work in the setting of some of these types of mutations. And that's really important because we want to avoid using potentially more toxic treatments like IV chemotherapy. And some of these newer drugs, these next generation oral anti-estrogen drugs, have already been shown to be particularly effective in the patients that have developed the ESR1 mutation. So with that in mind, the SERENA-6 study was a really interesting study where they took a large number of patients, over 3,000 patients, who had first-line therapy with an aromatase inhibitor and a CDK inhibitor. So for example, anastrozole with ribociclib or palbociclib, which is the standard treatment. So they were following these patients with blood tests every 2 to 3 months, looking for the development of that ESR1 mutation in real time, rather than waiting for clinical progression or for radiographic progression. And if they found that ESR1 mutation, they then checked the scan. And if the patient had no signs of any progression yet on the scan, but they had the ESR1 starting to rise up kind of in secret, they were randomized. Half the patients continued their current therapy, which is what would be happening now in the real world, and half the patients switched to a new oral anti-estrogen medicine called camizestrant, and the CDK inhibitor was continued. And the concept here was, what if we catch that ESR1 mutation right when it appears, right as it develops? So if we can use these amazingly sensitive blood-based circulating tumor DNA monitoring assays and identify these very small populations of cancer cells that are starting to break through treatment and personalize the therapy to prevent that, we can hopefully keep patients on less toxic, more tolerable treatments for longer periods of time, improving, hopefully, both their quality of life and their survival. The preliminary outcome from the study that we saw just at ASCO a couple of months ago suggested that the patients who switched got a benefit on the order of approximately 7 months. If you looked at the patients who stayed on their current therapy versus the patients who switched, it was more than a 6-month improvement in time on drug. There was also a very significant improvement in what they measure as time to deterioration in quality of life, meaning the patients who switched early felt better for longer, more than a year in terms of the deterioration in quality of life if they switched onto the newer drug. So this is really exciting data, but we need to see a little bit more. We need to see what happens to the overall survival of that cohort. We need to see what happens to those patients in the second and third line after they switch to this newer drug, because we don't know much about how resistance develops to these newer next generation oral antiestrogens. So it was a really exciting study. It was a positive study. It seemed to provoke potentially really meaningful improvements in quality of life and symptom burden, and also in control of disease for these patients. So I think we, as an oncology community, those of us who treat breast cancer, as well as any oncologist who treats solid tumors, can look at this study and be excited about the future deployment of these circulating tumor DNA sequencing technologies to both monitor the state of disease and allow us to make informed personal therapeutic decisions. And so I think the opportunities here are endless, not just for breast cancer, but across other tumor types as well.
If you want a refresher on the different types of hormone therapies, or if you want to learn more about how ESR1 mutations impact metastatic breast cancer, check out the videos linked below.